The following program is brought to you by Winthrop University Hospital. It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz, where you can get simple, straightforward answers to your questions about health. From diet and supplements to lifestyle changes. To reach Dr. Katz, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York. Here is Dr. Aaron Katz.
Good morning, everyone, and welcome again to another live round of Katz's Corner here on WABC Radio in New York. I'm your host, Dr. Aaron Katz, and we're live at 1-800-848-WABC. That's 1-800-848-9222 if you have a question. I hope you're all having a wonderful weekend. The weather is certainly terrific this weekend. Beautiful outside. And today's show is going to focus on something that has been talked about here on Katz's Corner. It's been talked throughout all of the urology conferences for many years, but especially over the last few years. And that is the area of PSA and its role in screening. And this week in the New York Times, there was, in my opinion, an outstanding and excellent, if you haven't seen it, op-ed piece by my guest this morning, Dr. Deepak Kapoor. And I've known Dr. Kapoor for several years. He's an outstanding urologist. And he wrote this article, which we're going to talk about, based upon some of the I think his thoughts about the United States Preventative Task Force on PSA screening, which came out a couple of years ago, really stating that men who have no symptoms should not be screened by PSA. And unfortunately, on that task force, there were no urologists, and this recommendation really came. There was a lot of pushback from urologists who use the PSA screening and have seen the benefits of PSA screening. And so Dr. Kapoor wrote this article. He is the president of Advanced Urology Centers of New York, and he holds the title, the academic title, of Clinical Associate Professor of Urology at Mount Sinai School of Medicine, and currently the chairman of the health policy of the large urology group practice associates in the United States, with an extensive experience and a background both clinically and he's also well published and has done a lot of work in the area of molecular biology and prostate cancer. So good morning, Dr. Kapoor.
Good morning, Dr. Katz, and thank you very much for having me on this what looks like to be a beautiful Sunday.
Yes, and thank you for taking the time out. This article was terrific. The points that you made were just spot on and right on, especially and it really spoke to the urologists and to the public about PSA screening. Tell us why you decided to write this article now.
Well, I'm glad that you led off with that question because I've been experiencing a great deal of frustration, and I know your show really is about health issues in general, but I know as a urologist yourself, urological issues are particularly important to you. But we've seen a really dramatic change in our practice, and I know you've seen it yourself, and urologists across the country have seen it. We're getting a lot fewer men who are being referred to us for evaluation of possible prostate cancer. As a consequence, and this is a direct consequence of the USPSTF recommendation that no asymptomatic man be screened. And since Aaron, both you and I know that the most common symptom of prostate cancer is no symptoms, that means that essentially we're just evaluating fewer men. So what we're seeing is a decrease not only in the lower grade, lower stage, less aggressive prostate cancers, but a decrease in the absolute number and the relative risk for developing higher grade, much more aggressive, difficult to treat prostate cancers. So the frustration for me is that if with the USPSTF recommendation, we were simply culling out patients that we didn't have to biopsy or didn't have to treat, well, that would be a good thing. But instead, we're just screening a lot fewer men. It's a very blunt tool. And the reason I wrote it was that it may take years for the USPSTF or for us to pass legislation to correct this. And I wanted men to understand that screening for prostate cancer is not a blunt instrument. It can be a very nuanced and personalized process. So I was hoping to inject that concept of personalized medicine into this dialogue.
Yeah, you mentioned in your article, you state that those decisions by the United States Preventative Task Force did not take into account adaptations that urologists have made to better identify patients likely to develop prostate cancer. Some tools that you state, these PSA derivatives, which were developed, I guess, in the mid-1990s, have been used, and they did not even look at these PSA derivatives to help us give patients a little bit more personalized approach. And this is another point that you make in your article. Tell us about this more personalized type of screening in 2015 that perhaps the task force didn't even look at.
Right. So what the task force did was take a look at screening for PSA at an absolute cutoff level. So as urologists know, and what most people understand the quote normal value of PSA is to be at a level of 4 nanograms per milliliter of serum. And the technical details of that number isn't important, but let's just say that the historical absolute cutoff for a PSA value was 4. Well, that's just a very static reading. And we understand that the PSA fluctuates with a variety of physiological conditions. It can be elevated by conditions other than prostate cancer. And in addition to that, PSA exists in a bound form to proteins in serum. So there's a variety of our understanding over the time where PSA was developed and released in 1986 by the FDA for general use has become much more nuanced. Now, what's different now is that historically we looked at a variety of different characteristics of PSA. What was the PSA related to age? What was the PSA related? How did the PSA change over time? What was the ratio of PSA that would be existing bound to protein or in a complex form relative to the circulating PSA? Sort of an analogy is like good and bad cholesterol, though it's an imprecise analogy. But when you look at these factors historically, like in the 90s and the 2000s, urologists didn't understand the biology of PSA quite so well because it was a new test, and we were looking at each one of these different PSA derivatives in a vacuum. And over the course of the last 5 to 7 years, we've understood that you can actually combine these PSA derivatives in a variety of new and interesting ways to really be a lot more specific on who needs to be biopsied and perhaps for whom this PSA abnormality is really related to other pathology or normal aging.
So what I'm hearing is that if a gentleman comes in and he's referred by his internist, and by the way, you're right on about the age cutoff and this PSA cutoff of 4, which we really should be getting away with, because I saw a gentleman this week in my office who's 35 years old, who has a very strong family history of prostate cancer. Both his father and his uncles have prostate cancer, which, again, I don't believe that the task force took that into account. He comes to my office, and he's 35 years old and has a PSA of 3.5. And I think that you and I would both say, wow, I mean, 3.5, although it's showing up normal on his lab values, I think you and I would both agree that this would be extremely abnormal for this 35-year-old gentleman who definitely should have further evaluation in the things that you talk about in your article.
Yeah, I mean, this is Aaron, I'm so glad you hit upon the point of the family history of prostate cancer. This was probably one of the most glaring omissions from the USPSTF, and I know it's frustrated you as well, is the failure to acknowledge that there are subcategories of men that have different levels of risk. I mean, and you hit on one of them, and of course, we also need to make everyone aware that those men with African American background are of significantly greater risk of developing prostate cancer. And so if you take a look at simply not evaluating those who are at greatest risk for the disease. And I concur with you. That 35-year-old man with a PSA of 3.5 and a strong family history of prostate cancer, that's a guy that definitely needs further evaluation. And it's those types of nuanced approaches. It's interesting for me. And I don't mean interesting in a positive way, that as we seek in virtually every other aspect of medicine to move toward more personalized care, right? We're analyzing the human genome. We're studying genes that may either trigger or suppress disease. That in the disease that's the most commonly diagnosed solid tumor in men and the second leading cause of cancer death, a government agency is recommending taking us away from personalized medicine into a one-size-fits-all treatment. And it just doesn't make any sense to me.
And just wondering why a task force from the government agency would come out with such a statement like this.
Well, the USPSTF, and you mentioned earlier that it didn't have a urologist on its panel. Not only did it not have a urologist on its panel, it didn't have any doctor that had ever treated anybody with prostate cancer. No medical oncologist, no radiation oncologist. So nobody at all that was experienced in the disease was involved in this. And the supporters of the task force say that that's a good thing because they don't have any professional bias when they analyze the data. But unfortunately, it also deprives them of the ability to really look behind the study. So how did they come up with this recommendation? Well, there's two very large studies that I know you're very conversant with that looked at prostate cancer screening. One was a study that's called the PLCO study, the prostate, lung, colorectal, ovarian study, and the other was the European randomized screening for prostate cancer trial, the ERSPC trial. And so in these two trials, they had wildly different conclusions. So the European study was 160,000 odd men, while the PLCO was about 80,000 men. So they're both very, very large studies. But both of them were constructed differently. Now, in the European study, they found that screening did produce a survival benefit. But in the American study, the PLCO, they did not find such an advantage. And the task force placed much greater weight on the PLCO study than they did on the European trial, which is fine if they chose to do that. But the problem was that both these studies had really significant methodological flaws. The European study, which was positive, was a multi-country study, and the criteria used in each one of the countries was slightly different from each other. But the PLCO study, the big problem was that rather than comparing screening against no screening, the PLCO study compared screening against what's known as what they called usual treatment, because they found that so many men had PSAs in their lifetimes in in the United States, that they would have difficulty accruing enough patients, gathering enough patients in the study. So rather than compare screening against no screening, they compared screening against usual treatment. Unfortunately, in the usual treatment arm, their control arm, 55% of men at some point in time had screening for PSA. So the PLCO study compared screening against 55% screening. And in that group, they didn't show a difference. So here you have these two large studies that are both methodologically severely flawed and produced contradictory results. So then the USPSTF went one step further. The risk to screening is negligible. It's a blood test, perhaps with a brief physical examination. But what they did was they took at the risk. They said that, okay, if you have screening and there's an abnormality, you're going to have a biopsy. And if you have a biopsy, you're going to have surgery or radiation or some other thing happen to you. And all these potential bad things can happen. And so what they did was they combined the risk of screening with diagnosis and treatment, and then concluded that nobody should ever have a PSA done. Nobody should be screened.
Yeah, and I think that's the And then when you finish the article, I mean, one of the last things that you say is that men must understand that screening does not commit them to further testing and even treatment, and even if some abnormalities are found. And so what I'm hearing is that today, when a patient comes in, when a man is referred in from his internist with an elevated PSA, there doesn't always have to be this knee-jerk response of doing a biopsy, that maybe we should be doing some of these PSA testing, like you said, this free and total PSA, the urine marker that you mentioned in the article, the PCA3 gene test. And even now, there's been a push to do more MRIs of the prostate to see if there is an abnormality in the prostate and whether there's a focused lesion, and we could potentially do targeted biopsies rather than just more random biopsies. And the idea here again is, and if you're just tuning in, we're talking with Deepak Kapoor, who's president of the Advanced Urology Centers and clinical associate professor of urology at Mount Sinai and chairman of the health policy at LUGPA, the Large Urology Group Practice Associates, who wrote an article this week in the New York Times. It's titled "The Bring Back Prostate Cancer Screening." We need to bring back the screening. And I've had multiple conversations with Ed Randall, who's another radio announcer, baseball announcer, who's established a foundation called Fans for the Cure. And he's very strong and very adamant that all men should be screened. What do you recommend now for your patients, Dr. Kapoor, about prostate cancer screening?
Well, I think it's important for men to understand that a PSA is just simply a piece of information that they can use to make better informed healthcare decisions for themselves. So when we take a look at the current, my recommendations are really based on international consensus guidelines. And so let's take a look at where we start with. We now understand that pretty much everybody should get a baseline PSA sometimes in their 40s, okay? And this is just a foundation from which they should build. Now, based on that foundation, and depending on how high that blood level is, because we now know that men who by the time they're age 45, if their PSA is below a certain threshold level, their lifetime risk of developing prostate cancer is lower. However, that has to be adjusted based on family history and race, with those with a positive family history or African Americans needing to be evaluated more often. Also, those of some of our veterans who have served that may have been exposed to Agent Orange. There's some evidence that suggests that they have a higher incidence of prostate cancer. So my strongest recommendation is that men get a baseline PSA sometimes in their 40s. Based on that baseline, as well as consideration of their risk factors, they should have a conversation with their physician about developing a customized screening program for them. It may not be necessary for them to get another PSA for 5 years, or depending on their risk, they may need to get one in a year or 2 years, depending on what that baseline is. And once they establish that screening regimen, talk to their doctors on an ongoing basis as to whether or not that regimen needs to be modified. And in this way, developing a customized program of overall prostate health in conjunction with their generalized men's health will really increase their chances of detecting significant cancers that need to be treated and cut down on the likelihood of running down false red herrings or false positives.
Do you think we're at the point now where this task force needs to look back at their recommendations and say, look, we have these new tests, these new ways, these PSA derivatives, and we should now take a different approach because this task force recommendation has transferred over to even the Affordable Care Act now, where they're now and Medicare, where men that are 65 years and older, they may not be covered for PSA testing anymore.
Yeah, and that's one of the things that people really need to understand, and this is really getting into lifting the hood politically, if you will. But under the Affordable Care Act, the USPSTF, the task force, historically their recommendations were purely advisory. Now, under the ACA, their level of authority has been elevated so that now Medicare can use them to make payment determinations. Now, what the public doesn't know is that the task force is one of, if not the only organization in the federal government that can make payment policy, that can be used for payment policy, that is exempt from the Sunshine Act and what's known as the Administrative Procedures Act. So, yeah, we're working really hard to reform the task force. Now, remember, this is the same task force that said that no woman should get a mammogram and other sorts of things. And they're not obliged to make their findings public or release their emails or even share what kind of biases their members may have. They're exempt from all those disclosure requirements. So there's actually a bipartisan bill in Congress right now to reform the task force and to make it more transparent and more accountable to the American people. Nobody's saying we shouldn't have a task force, but we're saying that if they're going to be able to make policy that affects people's lives, that we should be able to see to look under the hood and see how they operate, and they should be. And the public should be able to comment in the same way that they do on any other process that occurs. Because in the field of science, there is going to be dialogue. So, but and that's a bipartisan bill that's currently introduced. So I would encourage everybody who may be listening on the phone to call their representative and support Congresswoman Blackburn and Congressman Rush, but one a Republican, one a Democrat from Tennessee and Illinois, respectively, in their efforts to reform the task force bill. So that's to reform the task force. That's the first thing. The second thing is that we never really had broad-based population screening. It wasn't something that like immunizations for kids when they were younger. PSA testing was really always a choice that patients made with their family doctors, and now that choice is really being taken away because a lot of folks just simply aren't ordering that blood test. So you're right. The task force needs to look at the recommendation and understand that the science around screening really doesn't make a lot of sense now. To look at studies that had arbitrary cutoffs of PSA and consider that the gold standard of science right now simply doesn't make any sense. But both the legislative process and the task force reviewing it, that may take years. And unfortunately, and I know you're seeing it, we're seeing people that are being diagnosed much later. We all know about the grading and staging of prostate cancer. And as a urologist yourself, you know that if somebody comes in with a high-grade cancer that's occupying a lot of the prostate, their probability of cure goes down dramatically. We do much better with prostate cancer and, quite frankly, every other cancer if we can get to the disease early. So,
yeah, no doubt. We don't want to go back to those days when men are coming into the emergency room with spinal cord compression and bone pain. That's the idea behind this test. And you're right, it's not a perfect test, but we have tools that we can use as physicians and be smart about it and be personalized. Now, beyond the screening, do you think that we've made the same headroads in terms of treatment? So let's say a man has a biopsy. Do all men need treatment? Have we done the same thing here? Can we go more personalized today in 2015 so that not all men have to undergo, let's say, radical therapies?
Absolutely. I mentioned in my article we've got a variety of genomic markers. We've got these things that are known as epigenetic testing, which is measuring the behavior of genes. So once we identify a man, historically speaking, if you have a cancer occupying a lot of your prostate that's very aggressive, you're going to need treatment. There was never a question about that. But there was this whole range of intermediate grade prostate cancers where the majority of cancers fall, that some of those are going to turn out to be bad actors and some of them are going to turn out to be much more indolent or slow growing. Now, critics of urologists and critics of PSA testing have said that, urologists are just simply looking to treat everybody because that's our business and we want to just treat people. And Aaron, and I know you find that really insulting, and I think that that's so offensive because, the reason why these men historically got treatment, and in retrospect, when we look back, that we may have overtreated men wasn't because we were trying to expand our business. It was because we didn't have any way to differentiate those men with intermediate-grade cancer who were going to die with their disease from those men that were going to die of their disease. So we didn't have a way to refine that biopsy, that Gleason score, into something that was more accurate.
Right,
So, when you don't have any information, you sit down with a patient and you say, look, these are the upsides, these are the downsides, what do you want to do? And faced with no information, most patients will make the choice to have therapy because the downside risk of death is just simply too great. That doesn't exist anymore, Aaron. We're not talking about that. We don't have that vacuum. We now, with a very significant degree of accuracy, are going to have developed tools to say, okay, you've got an intermediate-grade prostate cancer. What's the chance that this intermediate-grade prostate cancer is going to turn out to be a killer? And now we've developed these protocols known as active surveillance protocols, which means that instead of just not treating somebody, we actively follow them with a prescribed regimen of blood tests and sometimes rebiopsying to see whether or not their disease changes. So right now, if you look across the United States, the percentage of men with intermediate-grade cancer that are being treated is about 40% of them are having their treatment deferred. Now, ultimately, some of those men may later require treatment if their disease starts to progress, but the point is that we're not looking to treat everyone, and we never were looking to treat everyone. We're looking to treat people that need to be treated. And what's different now is that we're much more able to tell who those patients are. And that's something that people really need to understand. Again, you made that point right before we had some technical problems. A PSA is just a piece of information. It doesn't oblige you to have a biopsy, and if you have a biopsy and you have cancer, it doesn't oblige you to have immediate therapy. It's simply a piece of data that you can use in conjunction with your own research and your doctor to make the best informed healthcare decision for yourself. And nobody should let a government agency deprive them of the right to have information to make the decision. I'll just leave you with one anecdote. The USPSTF is a branch of a part of the executive branch of the government, which is run by which is under the auspices of President Obama. And this isn't a political statement, but the USPSTF recommendation was so far out in left field that after they issued their preliminary recommendation in 2010, 1 week later, the President of the United States had a PSA done. So my question to everybody listening is that if the test is good enough for the President of the United States, why isn't it good enough for you?
Absolutely. I mean, and I want to congratulate you again for this article, and it brought a lot of attention. Many of the patients that I saw came in, and we're talking about the article. The points in the article are terrific. If you haven't seen it, it's Bring Back Prostate Screening. It was in the New York Times this week by my wonderful guest this morning, Deepak Kapoor. And if you want to learn more, I guess, Dr. Kapoor, you have a website about this information?
Yeah, there's ample information everywhere. The American Urological Association has a great website, and of course our own office, Advanced Urology Centers of New York, www.aucofny.com. That's aucofny.com has information as well. And I know, of course, you folks at Winthrop are very forward about educating. There's a lot of resources that are available for men that want to learn more about this.
Well, thanks so much for coming up this morning. This was wonderful information for our listeners and for their spouses, because it's also the spouses that need to bring in our men and make sure that they do get screened, as you point out very well this morning. Tune in again every Sunday morning at 7 a.m. This is Dr. Aaron Katz.